And I think honestly, probably private practice is better than academics because they are much more of a business than academics typically is just because of the size of the institution. But we don't really know what anything we do costs. You don't know what it gets paid because my salary isn't really linked to that as much.
You're listening to Data Nerds in the OR, a surgeon's journey toward value-based care. The podcast focused on data and data science as the keys to a better healthcare system. Ideas brought to life by the vision and experience of host Dr. Bruce Ramshaw. Each week, Dr. Ramshaw sits down with different players in the healthcare system to discuss how data is used today and what it could do if it were used effectively, how it could improve surgical quality, education, outcomes, and drive better patient care. Let's dive into the latest episode. Here's your host, Dr. Bruce Ramshaw.
Thanks very much. Today I'm joined by Dr. Peter Now. Pete's at the University of Iowa, and I had the pleasure of working with Pete on a variety of projects over the past couple of years. And so what I'd like to do is ask Pete to introduce himself, tell us what you would like us to know about you, and then begin to talk a little bit about your experience as a busy clinician and also an academic educator about what you have experienced with healthcare data and opportunities to have a better, data science driven world in healthcare. Maybe if you can start with the introduction and talking about your experience with data in healthcare so far.
Sure. Thanks for having me. Like Bruce said, I'm at the University of Iowa. I have about a 3-part practice, really. I do about a third bariatric, a third abdominal wall, and a third benign esophagus. We do have a fellowship here, which is where I do most of my teaching as an academic person. We do have residents, obviously, but the majority of our longitudinal teaching is with the fellows we have each year for our MIS bariatric program. For me, as far as my experience with data, we do get data from the MBSA-QIP data harvest, but it's really not helpful data. I mean, the sense that when you look at the MBSA-QIP report, it as expected or outliers, and it's very non-transparent, and it's hard to know where their quartiles fall. It's hard to know what to use with that data. And when we start trying to respond to the data, it's also hard because if you just had 2 or 3 events that might take you from as expected to an outlier, but you really don't have any way to, from what they're collecting, to do any sort of deep dive into what happened or how to change it. And so then when you have, if you have outliers, which is thankfully uncommon, you have to create a QIP or a quality improvement project, but really without any data to sort of make it transparent. Hey, this is what's going on. We need to fix it. And so it was always kind of frustrating before I started working with care plots because all new data that we had wasn't super helpful. And then when we were trying to respond to it, it was difficult to really know what we were responding to.
And is that mainly through the hospital? Does the hospital provide you with that data?
And if you're an MBSA-QIP center, you have to have a data extractor. And so that person pulls all the cases done by the bariatric surgeons, as well as, if someone comes in with emergency general surgery with a perforated, septic abdomen, and they do an X-lap and take apart their GJ, and then we help them put that back together, or they put it back together. That all falls under the same umbrella. So that bariatrics person will capture any bariatric case. So the bariatric data extractor will capture any bariatric case done at University of Iowa, and that's part of the MBSA-QIP registry process. Very similar to NISQIP, just for bariatric cases only.
Right. So you're limited to bariatric. Do you get any other kind of data from your other cases, like hernia or?
No. And, but the best thing that we tried to do when we it was probably 7 or 8 years ago, myself and a couple of my partners decided to really try to streamline our hernia, not our abdominal wall practice, because we had so much variability, both in the outcomes and in the approaches. Now there's still quite a few people doing IPOM and really wide defects, or kind of the same hernia repair for different hernias, regardless of what was appropriate. And so we tried to streamline it and create some data-driven practices. A1C, hernia defects, obesity, smoking status, things like that, to try to get better outcomes. But it wasn't as much data-driven as it was sort of perceived inconsistencies in the institution with people on how they practice that, how they practice abdominal reconstructions.
So that's, it's disappointing. I had the same issue in my practice. Now, there just wasn't really any good data infrastructure so that I could, monitor my outcomes. And then the other piece is data entry. Maybe talk a little bit about, a lot of the people listening probably are clinicians, but maybe not. So maybe talk a little bit about your experience in data entry into the electronic medical record. What's that like?
So as far as extracting it for research or just in general?
No, just having to enter it into the electronic medical record.
Yeah, I mean, I think a lot of it's just driven by billing, right? Like anymore, it's not, it's the data that you collect is only, it's not good data. Like for instance, I just realized this, but if you do a recurrent periesophageal hernia repair, this is the same CPT code as a primary repair. But when you're talking about risk for recurrent, certainly if you're doing a recurrent repair, it's more likely. There's nothing in the electronic medical record about the number of stitches that you put into the crura, how big the hernia is. It's all subjective. And so when you look at like a foregut operation, I think one of the reasons why we don't really know what the recurrence risk is or haven't defined how we fix it is everybody's measuring it differently. They're using, sutures differently. They're using mesh differently. They're fixing mesh to the abdominal wall differently. What's a big hernia knee may be a huge one or a small one to someone else, and how we highly get into the mediastinum. And so, there's really no good way to document that stuff except sort of individually so you can go back in. So like, for instance, more recently in the past year, I started documenting how many stitches I put in the crura to repair it, because I think that if I go back and there's 8 stitches placed in the crura, that was clearly under more tension than if I put 2. And I think that hopefully will help me in 5 or 6 years when I go back in and this person's come back and not Bob. Similar with the abdominal wall, we more recently had the data that we put in really is just again based on billing, based on the size, and it doesn't have anything to do with the complexity of how we do it. It could be a very straightforward twist cheese hernia that's 12 centimeters tall and 2 centimeters wide, but it all documented is greater than 10 centimeters versus one that's 9 by 9 centimeters that you're doing a really difficult, complex where the posterior sheath isn't reaching and you're doing tar versus burning posterior sheath. That one will actually show it less complex. And so the data going into the electronic medical record is really for billers, and it doesn't really help people that are trying to figure out their quality or why they lack quality or why their quality is better or why they're struggling in certain cases.
And ideas to get better. How, if we can't see our data, we can't learn from it, right? And I imagine the residents are the ones that enter data into the EMR for you. Is that true? Or
so I do all my own op reports. Super and retentive, which I'm coming there. So, but I think also when I first started and I wasn't as busy, I came to realize that my billing wasn't good. And so I had to meet with our billers a lot because I would do a case and they wouldn't bill it accurately. And I wasn't getting credit for the work that I was doing, or we had to think around outside the box. Does I do a laparoscopic gist and get an unlisted stomach procedure for 8 RVUs, which is wildly insufficient. And so I had to start working with them to make sure they were doing the right stuff. And that's when I realized that I had to put, if I'm doing abdominal reconstruction, I list like the borders of my dissection, the height of my dissection, the size of the mesh that we put in, where we put the mesh. Like I put all that in there because it's the only way for me to know that I was getting billed correctly. That's why the data goes in the way it goes in, is that again, it comes down to making sure that I get paid and get the RVs I'm supposed to, because that's what my salary is based.
What about your H&E data and other clinical data? Who enters that?
Well, I half and half. I have residents occasionally in a clinic. It's very hit and miss. So for bariatrics, it's very, again, it's to meet their qualifications. So we put in the stuff that we need to put in so that the patients get their surgeries approved. For me, for my hernias and foregut stuff, that I had templates that I developed that I hope that they can get them the residents to use because it streamlines stuff for them, but also it gets the information we need in there. But again, when you look at foregut stuff, when I say a massive periesophageal hernia, that's like the spleen is the only thing left in the abdomen, and I had transverse colon and small bowel. But if you look at a radiologist, they'll say giant hiatal hernia or large periesophageal hernia, and it's only be a moderate or small to moderate for me. And so it's always, are we comparing apples to apples, or are we using the same verbiage? And often not.
Yeah. There's so many. I mean, you described it well, kind of the limitations of the current data repositories, the EMR systems, and how they're more geared towards documentation for coding and billing rather than actual high quality data so we can use it for learning and improving. I think that's one of the biggest flaws in our system is a design error. There was actually a publication out of the University of Pennsylvania, I think a year or two ago, and they studied many years worth of all of the documentation and all of the clinic notes, hospital notes, and they found that over 50% were just copied and pasted. So I'm sure you're not surprised, right?
Well, in fact, the residents and the medical students, I asked them to just, because if you look at our notes, it'll say bariatric surgery, or the most common thing is they've had a gastric bypass and they've had a sleeve, or they've actually had a VDG. So if you look at notes that are written by me, I don't use any of those. I'll verify it in the electronic medical record, but then I erase everything that's self-populated so I know when I go back that it's actually real, because so often, I mean, I don't care about ortho procedure. Not that it's not a great specialty. It doesn't influence my practice. And so I'll just put ortho procedures. But for abdominal wall stuff, I want it in there and I want to correct her. If it's bariatrics, it can't just say bariatric surgery or abdominal surgery. It's got to have some sort of relevance. And so I actually don't use the electronic medical record to document for me because it's so often incorrect. And I just don't know.
And you put that extra work in because you care about the quality of the data that you're entering, but you're an outlier, right? Most.
Well,
yeah. Well, that's
when you're doing abdominal wall stuff, or, if you're trying to go back into someone's abdomen for the however many time, even if you're not doing an ab wall case, then you don't, if there's abdomen surgery and you go in there, it's like there's a squirrel running around in there versus there's nothing that's happened before. I mean, you have to know how to educate patients on what to expect post-op and what the risks are. And if you don't go through that information and get a clear idea of what's actually happened, you can't tell them how much it's gonna be dangerous or it should be straightforward.
Yeah, that's one reason why we work together. It's a pleasure working with you because you're passionate about your data, and that's so important to get good quality data. We'll talk about that some more. I want to do a little pivot right now because there's another type of data we haven't talked about yet, which is video data. I think, University of Iowa has had our MCX advanced platform with video data for a few years now. And so I want you to talk about some of the uses you found with video data and some of the value of using video data for a variety of applications.
So the biggest thing that we've used it for is our fellow. I really like teaching residents for the whole of my practice here, and a couple of parts with them. One is, I have my foregut practice is we just don't see a whole lot of small hernias. A lot of them are pretty big just because the smaller ones get sucked up by the private hospitals surrounding. And so a lot of times when we're dissecting 7, 8, 9, 10 centimeters into the mediastinum with a third year or fourth year, it's just kind of beyond their expertise. And so they don't get to do it as much. And so I can teach them with the video, but getting them to actually do the operation is more a bit frustrating because they're on our service for a month, then they rotate off, then they see one operation. It's a pretty difficult operation for them to deal with. I've seen one, now I can go out and operate in between the heart and the aortas a little bit outside of the scope of their abilities. Whereas with fellows, we have this longitudinal experience where we're with them all year. And that for me is really rewarding and fun because you get to see them. So you know where you can trust them. You can know what their limitations are, whether they appreciate their limitations and know what to expect from them, which is really important when you're trying to, keep bad things from happening, but also learn how to teach them. Some people you need to be the gas, some people you need to be the brakes. But with the video, it's been great because every year the fellows come in and they have a Dr. Lehman bypass and a Dr. Smith bypass and Dr. Now bypass that they can watch. And they have examples of those on a hard drive so they can say, this is what I need to do or in this case. And then early on, they can watch that a lot and get comfortable with it. And then later on, when they're doing more and more, every Friday that we have bypasses on Wednesday, we'll go Friday and we'll watch the case. And we can sit down and, because in the operating room, we have to be efficient, right? We have people that aren't necessarily healthiest on the operating room table, but also we need to get our cases done so the nurses don't stay late, so I don't get less time to do the cases I need to do and lose access to the OR. And so by saying, okay, we're going to give you a chance to fix it or to do it, and then I'll say, we'll go over it afterwards. Then on Friday, we can sit down and just with any computer, pull up the website, pull up the video and stream it and show like, this is what I meant when you got the stapler. So like, for instance, last week, the fellow was struggling to get the stapler in to create the common gastroenterostomy, and he got it. But then on Friday, you could sit down and I could say, see, this is what I was saying. I think that the light bulb turns on a lot faster, because it's not just me telling them during the case when it's high stress and they're trying to get it done. They don't want me to take that part away from them, and they want to finish the case themselves. But then they can do it. And then Friday they can sit back. And I think that they realize a whole lot quicker when it's sort of a de-stressed, or, we de-escalated the stress, how much faster they pick it up, because they can watch it and learn from what they just did a couple of days ago.
Right. And then, you hear this all the time, but other industries, including sports, use video all the time. I remember I played high school football in the 1970s, and we watched video of our games and reviewed tape. This is not new, but it's just not common in healthcare, unfortunately. So
I think we've had to get past, I think one of the nice things about care syntax that makes people comfortable when we talk about it is this idea of a patient safety organization role, because I think for a long time, I didn't record stuff because I was a little bit nervous about recording it. Where do you keep it? What do you do with it? Are you putting yourself at risk? There's a lot of people that don't want to record stuff because they're afraid if they record it and then there's a complication, then all of a sudden it's discoverable. And so I think having to be a PSO where the patients know it's there, where it's under the auspices of a safety, gathering, improving quality situation, it makes it a whole lot easier just to record everything versus or record the hard case. And then if there's a complication, then like this recording it out there. And I know that there are a lot of people that get gun shy about recording, which is, an unfortunate reality in medicine and life in normal. But I think that that's something that this platform gets around in a good way.
Yeah, and it's very positive. There's a lot of science behind safety and system science, and it really is important what exactly you said, not to use data for blame and shame and punitive purposes. Vast majority of people in healthcare are trying to help patients and have good intentions, but we're all human, right? So we make errors. It's important to have a safe environment where we can learn from any kind of errors, most of which are not intentional by far, but they happen. We have complex patients like you described. My hernia practice had a lot of complex patients, and you knew there were going to be some complications because somebody who's had 10 prior abdominal wall hernia repairs and their loss of domain with intestines down to their knee, that's not a simple operation. So yeah, you need a safe environment. And that's really important that we get comfortable with transparency of data and the fact that we don't use data to blame, shame, and punish people. We use it for learning and improving in the right ethical, supported by science kind of environment. Let's pivot a little bit again, because there's another group set of data that we haven't talked about yet. And I think we can bring all this together to bring video data with clinical data. But how about financial data? I know in the last few months, we've worked together on some financial data to put it with clinical data. We talk about value-based care recently all the time in healthcare. You see people all the time talking about value-based care. And yet I've very rarely seen anybody put financial data with outcomes data to truly measure value. And we've begun to do that. What is your view on that? Do you see, what kinds of benefits do you see with that?
So our hospital, and I think a lot of hospitals think this way, is their idea of improving what we take in is just to run the system leaner and to do more with less. And I think the reality is that you can only run the system so lean, and then you start decreasing quality, improving or decreasing. If it's not quality, then you just have nurses that are overworked or surgeons that are overworked, and then you lose good people because you're making them do more. And so I think that's the first thing that we have to get past, is stop saying, oh, we're just going to do more with less, or we're just going to put more cases in the OR, because at some point the system can't really run more efficiently, and you're actually on the wrong side of the slope, and you're either losing people, losing surgeons, or having quality go bad. And so I think that part of it. I think the other thing is, and I think honestly, probably private practice is better than academics because they are much more of a business than academics typically is, just because of the size of the institution. But we don't really know what anything we do costs. We don't know what it gets paid, because I'm not my salary isn't really linked to that as much. I mean, I guess sort of a little bit and not in any transparent way. So I don't know what the hospital, I still don't know what the hospital gets for a paraesophageal hernia repair for a bypass. I know what my dollars per RVU is in the data that I get, but I don't know how real that really is because collections is way different than billing.
Right.
And I don't, and if you start doing the robot, well, are you including how much the robot costs or the person and our robot coordinator with a 1 FTE equivalent and all the benefits and, the contract that keeps it going every year? Like, what does all, if we're using the mesh, we're using a mesh that someone with on contract, or using one that's not on contract, and what's the difference in price? You don't have any idea what that is. And, the only thing I ever ran into really was when I started trying to do links because I can never get links fixed. And so the only way for me to really do links here would be to do a paraesophageal hernia repair and then write off the cost of the links. But I think at that point, the margin is in the negatives. And so I never did it because I knew the positive take home might be $6,000 or $7,000 and the links is $7 or $8,000. And so that's kind of the tip of the iceberg when you talk about how we approach stuff. And so if we want to start making more money or running a more profitable business or reimbursing or paying our surgeons or our nurses or whoever better, we can't just do more. We have to do more in a way that's thoughtful. And maybe it means that we have to get rid of mesh, or we have to study it so we know that mesh is worth it.
Right.
Or, we shouldn't be doing robots for gallbladder because they lose too much money, or we should never open a ligature for a gallbladder without some super extenuating circumstance because the margin for a gallbladder is too small to use certain stuff. And I think that no one knows that because we don't have that data and it's not given to the surgeon when, all they tell us is they can't pay us more, or they can't get us more nurses, and no one knows why. And I think that there's that disconnect between the administration, what they see and what we see. And this is probably a way to bridge that a little bit.
That's what we're hoping, right? We're hoping to use the principles of systems and data science to show how to put data together around the patient process and financial data with outcomes data. So we're truly able to measure and improve value. And the work that you're doing with us on that is just terrific. I think it's going to be as far as I know, it's the first time we're going to have surgeon financial data with RVUs, hospital financial data, and patient outcomes all together in one data set. And, it's kind of sad, but true that I've never seen that in healthcare before. So something that I think is going to be more and more looked at as, hey, this is a real solution. And this is something that we should all be doing. Along those lines, talk about in that context too, talk about what your view is on this effort to transform from a fee-for-service system, because you mentioned it, whether it's talking about cost cutting or volume driven, those are not sustainable. You can gain some improvement up to a certain point, but you can't make a surgeon do more cases. There's only 24 hours in a day. There's always so much operating room capacity, and then cost cutting. You can only cost cut so much. Then you start running into quality issues. So really, we need to shift the value from fee for service. But what's your view on that and our ability to do that as we learn the data science principles more and more?
I just don't think the surgeons know what's going on. And that's me too, so I used to use a certain kind of mesh for my laparoscopic retrorectus repairs. And then I actually had to pull the data, and it was a difference. If I used a different mesh, is a difference of $1,000. But and I don't know if we know what that's actually influencing the outcomes. Maybe that mesh was worth it because they're less likely to come back, or maybe it's not. So I think that until we can get some transparent data on what the cost is and how that influences the quality, and we can do some of that retrospectively, we might have to do some of that prospectively. We say, okay, we have this mesh, we're going to bring it in, we're going to see what the recurrences for a hiatal hernia are at 1 year. And if the recurrences are better, maybe it makes sense. But if it doesn't, maybe we're just costing the hospital $2,000. And at some point, hopefully, my hope would be that they can, if we can find a way to engage surgeons and say, this is helpful, you get to use this because this does make sense, but this is less helpful. Let's find a way that we can do something that's more financially beneficial, that there can be some sort of cost sharing, because I think the hospital usually tries to carry a stick a lot. And the stick only works for so long before people lose interest or they leave. Because what they keep getting told, you can't do this or you're not doing this right, it wears on you versus saying, hey, we're going to dangle a carrot and say, this is what your data shows. If you're willing to make these changes, maybe we can figure out what costs, some sort of profit sharing so that you see some benefit to making these changes versus us just saying, do this, do that. And so I think, but until we get data, we just don't know. And until we get data that's meaningful for the surgeon and not just meaningful for the billers, it's hard to take any information as anything other than just the administration carrying a big stick and wielding it to their, to what fit their priorities rather than what might help the surgeon or the patient.
Yeah, and I think that's a situation a lot of surgeons are in around the country, maybe around the world. But if we can all work together around value-based outcomes and give the clinicians, because it really is you and your team who has the ability to make decisions, but you have to have good data. You have to have good analysis of data so you can take those insights and apply them. And we're not doing that today in healthcare, but we're planning to do that now and into the future. I'm a little curious, again, a little bit of a pivot. As a bariatric surgeon, you're probably well aware of the recent GLP-1s and the medications. And right now they're all over TV ads, right? So it's all sell, no discrimination. Who would it be best value in what patient subpopulation? I think data science can help identify the appropriate use of medications versus the appropriate use of bariatric surgery, which I think both will probably play a role. But I've heard even recently that some payers are starting to guide patients back to bariatric surgery because of the cost of these new medications. I was wondering what your thoughts are on that and the data science that could apply to that issue.
I think it's a little bit dangerous how it's kind of rolling out so quickly. Fortunately or unfortunately, depending on how you look at it, Iowa doesn't have a lot of people that have the liquidity of their finances to be able to support the cash pay that comes with it. We don't have, I know there were some states like North Carolina that they used to cover it, that have since stopped covering it, but we've never really covered it here for a weight loss medication. A lot of people that are getting it, they're paying cash from a compounding pharmacy, and it may be only $500 a month rather than the $1,000 or something you get when you bought a brand name. But we see it, but it's not maybe as prevalent. My concern with those, and I think this is what we have to watch, is there tends to be really bad sarcopenia or loss of muscle that comes with that. And so then when people come off those meds, they typically gain their weight back, but then they lost a lot of their muscle. Their metabolic rate falls like crazy. So their ability to lose weight after that is actually worse because they don't have the muscle that they need to burn the calories, and metabolism's all screwed up. And so, I think that it definitely needs to be a tool in the armamentarium of obesity medicine / surgeon, obesity surgeon practice. But I'm not sure where it's going to fall because I don't think we know what the long-term effects are going to be for people that are taking up outside of diabetes. We certainly it's been around for diabetes for a long time, but we are seeing rapid muscle wasting, and people do they really want to stay on it for forever? Because when they come off, they typically gain their way back, and then there's the non-responders, and a lot of the data on the medicine, typically in people that have lower BMI, and the ones with the higher BMIs, they don't have as great data. And so I think that it's something we need to be I think this is the Pandora's box. It's not going back in, but I think we need to be pretty thoughtful about how we study it so we can find the right population that helps. Because the nice thing about a bariatric program is we see our patients at 1 week, 1 month, 3 months, 6 months, 12 months, and then annually we'll see them for whenever they want. And so they get a dietitian whenever they want to get a dietitian. You get to see us. And so there is a little bit of they have some, I don't know, skin in the game is the right word, but there's some accountability. There's a lot of support, and there's hopefully a lot of education. So it's not just go out and lose weight, but don't know why and don't know how to use it when you lose the weight. How do you keep it off? And I think that in some ways we have to be careful how we roll out these meds, because if they're not getting any education, dietitians, or any sort of learning taught anything about how to keep weight off and what weight is, what a calorie is, and carb and protein and fat is, we think there's going to be a lot of people that aren't going to do well, or when they come off of that, they're going to be in a worse situation than were before.
Yeah, and I think that's some of the concern with everything in healthcare that we do, whether it's a drug or a surgical technique or a diagnostics tool for that matter. In a subpopulation, it may benefit them. Hopefully there's a subpopulation that benefits, but there's another subpopulation may harm them. And then another subpopulation may be wasteful. It didn't help or harm them, but it costs money and time. And, you know, the data science tools, we can begin to understand those subpopulations when we have a data and analytics infrastructure to give us those insights. You mentioned sarcopenia, and I know we've worked together a little bit. You have a team of data scientists there at Iowa who's looking at sarcopenia as a data point or a set of data points to predict, you know, patients who may be not optimally prepared for surgery, especially major surgery. Maybe talk about that a little bit.
Yeah, I mean, I think that, so we always have that eyeball, right? Everybody, you can walk in the room and you see that 9-year-old lady and like, man, she's 70, you know, in her actual age versus her chronologic age. And then there's the other person that you walk in, you think, man, they're 70 going on 100, and I don't want to operate on them. But we don't have any way to objectify that or turn that into an objective measurement. So for a long time, we started out when I first got here doing some research just with a single slice of the psoas muscle, which really isn't a muscle that you should be able to exercise, looking at the density and volume, but it was a single slice. It was at a single level and relied on the false assumption that the psoas muscle is uniform in its shape. And so we developed this program that can measure the volume and density of the entire psoas muscle, hopefully trying to prove that to take that eyeball test of this person's, you know, there's sarcopenic obesity, where we know people that have both sarcopenia or lower muscle quantity and quality, despite them having obesity as a comorbidity. We know that sarcopenia influences outcomes in multiple surgical and medical populations, but we don't have a great way of measuring it because some of these false assumptions on how we decide to choose to measure it and where. And so hopefully we can take something like that says, hey, this is an objective measure of a muscle that should be indicative of their entire body's fitness, instead of the Charleston Comorbidity Index or the NSQIP, calculator, which is really onerous and also just lots of ones and zeros. And so if you take Pete now, who sees the doctor regularly, he can have high cholesterol, high blood pressure, but they're both very well controlled, but they're both, a positive on somebody's scale. So it makes me look less healthy, and it may not be an accurate indication of how healthy I am versus or not healthy versus something that's more of an objective muscle measurement. So that's kind of the goal. We still have to sort of prove it in bigger populations and try to get lots of data. Because I think, the tough thing is if we take 800 people for a study and there's only 20 complications, it takes more than 800 people to really get meaningful data on whether it changes their outcome that are linked to stay or cost or things like that.
But like you said, it gives us an objective way to say, hey, this person may not be optimally prepared for surgery, but then we need to move to a value model because we don't get paid to spend all that time and effort to help somebody in prehabilitation, counsel them about nutrition, exercise, even neurocognitive improvement. But yeah, I think it's where we're moving with data is being able to be proactive and help people have better outcomes through those kinds of data identifications. A couple other things I wanted to ask you personally, just things I saw on the website and just general. I saw that your father was in pediatrics and that some sort of influence in your career, but then you chose surgery. So I was just curious, maybe a little bit about the influence your dad had on you in terms of choosing medicine, and why did you go into surgery instead of pediatrics?
So I always wanted to be a doctor. Like I had no backup plan. And I just always thought that what my dad did was pretty cool. He used to take me to the NICU when I was a kid and walk me through the NICU, and I thought that was really neat.
That's awesome.
When I was 16, I had WPW syndrome, which is like a heart rate anomaly from a reentry circuit. And I did pediatric cardiology research for almost 2 years. And so I went into medical school absolutely certain I was going to be a pediatric cardiologist because I did research in it and I had a pediatric cardiovascular condition. It was, obviously it's gone. I got an ablation, but and then I went to my first rotation as a surgeon, and Dr. Habala, who's cold resized, we had two perforated or two ruptured aortic aneurysms came in at the exact same time.
Oh my God.
So the resident team was split very thin. So I was right up close. And I mean, I remember we opened up the abdomen, this was like third year med school, second day on surgery. I watched them open the abdomen. And then, of course, there's like this big rush, and Dr. Habala took the intern's hands and told her to put pressure on the aorta. And then he calmly dissected to clamp the aorta with his hands just below the diaphragm. Like, he was crossing the street, and he said, I have control of the aorta. Just like he just said, the sun's going to come out tomorrow. I'm like, my eyes were huge. That was it. That was all it took. And so that was kind of how it started. And then how all surgeons do it, right? I just got to Ohio State, and I really liked the guys that do the stuff that I went into, and I looked up to them, and I hung out around them. I'm not sure if I was with them when I was quite young, but I hung out around them and soaked it up and did research with them. And that's kind of how I went into what I went in.
That's awesome. That's a great story. I think a lot of us, went through that aha moment where, seeing somebody suffering or potentially dying. I can't imagine two ruptured aortic aneurysms coming at the same time.
He usually went home. He walked out of the hospital. I'll never know.
That's, I think you, me, most of us who go into surgery, it's not because we like to use our hands. It's because we like to see somebody who's suffering or dying, and we actively do something and it relieves their suffering. It's a privilege to be able to do things like that. So thank you. The last thing, just curious, if you've seen any books or movies, read any books or seen any movies lately that you think are worthwhile for somebody who's really interested in healthcare, surgery, or data science?
I read. I like to read, but most of the time these days with 3 kids, crazy sports. I read and then I'll fall asleep. I wish I had. I do listen to a lot of books, but I haven't started listening to those kind of books because usually it's when I listen to them when I'm out riding my bike. I haven't done a whole lot of good reading that anything healthcare related, mostly because it's just I'm so tired at the end of the day after being an Uber driver after work. If work Tuesday, Wednesday, Thursday, Saturday, Sunday.
Any good non-medical books that you've enjoyed lately?
Man, I'd have to go back. Like I said, I'm a big Stephen King nerd. I really love his books. What have I listened to recently? Oh gosh, I wish I would have looked. I'd have to go back through. There's a book that I listened to recently that Tom Hanks listened to that he narrated. I'm a big John Stanford fan.
So those are some good options. We'll put a list. We'll put a list with this podcast when we publish it. I always go to Moneyball, either the book or the movie. Have you seen the movie?
Seen the movie. I haven't read it, but I've seen the movie. It's a great movie.
Yeah, I always default to that. I hadn't seen it in a couple of years and watched it on the plane recently. I was like, hey, yeah, this still makes sense for healthcare.
Well, and it changed baseball, right?
Yeah.
I think there was a guy named Howard. I can't remember his first name. He played first baseman for the Phillies. I think he was basically put out of the game by the shift because he was a left-handed power hitter, and they put the shift in, and all of a sudden his style of hitting became unsustainable because they learned how to pitch around him and play around him. It changed the scope of baseball, and you see that now. Right? Steph Curry changed the way he played basketball because now they use analytics and they know that the way that he shoots, they'll pass up a layup for him to jack up a 3. And the analytics of sport have changed the way they play the game.
Yeah, we want to do the same thing they did to Howard, to cancer and other diseases, if we just use data the right way in healthcare.
2 questions from the audience here through this conversation. Really quick, Doctor. Now it's Ryan Howard from the Phillies, the first baseman.
Ryan Howard, yeah. He was out of the league in like 2 years after being shoot.
I don't know if I ever recognized that was a shift from the data analytics side that caused that, but he was an all-star, and then he quickly exited, right? Unceremoniously, yes. I'd like to go back earlier in the conversation. You were talking about your use of video data, especially in your ORs at university. I know you're using it, of course, in the perioperative setting and then in training, learning moments on Fridays. Do you see video being, and I know there's restrictions or pushback against it, are you seeing your fellows and your residents taking it with them? Are they trying to expand the use of this for their practices?
So Aaron and Ramses are the two fellows that we've had outside of our current fellow, that have been a part of the video part. And I know Ramses records these cases because of those. Ramses didn't leave with any videos because I think that would technically be illegal. Because that would be not according to how we recorded them. But I know that Ramses left, like Erin had a collection of videos that she left for Ramses that Ramses left for Leon. And so, but I know Ramses planned on recording cases and using them in the same way because he's an education, so he has Redland. Erin's in private practice, and so I don't think she's recording the same way. Although I wish that she were, because I think it'd be cool to see what changed after she left, both in how she became less efficient and how she became more efficient. Just necessarily you're less efficient after you leave. So I know Ramses is then to get married.
Thank you for that. Appreciate it. That's all the questions we have here. So, Dr. Ramshaw, I'll let you close it out.
Yeah, well, I'll ask one more thing and follow up to that. I forgot to mention, and I don't know how involved you are, but in addition to the surgical video, we also do in-room video. And I know through Michelle and others, there's been a lot of work on the team building for the OR team, turnover in between cases, during cases. Any view on the value of the in-room camera in addition to surgical video?
I mean, I think that we're just very much skimming the purple part of that one because we know that turnover can be improved, and we have seen situations where we've looked back and there's just been no one in the room. So we can see that and we can try to figure out why that's happening versus, why don't we have 3 people in the room cleaning the minute we're out? And so we can use it like that. I think we also know that there are some anesthesiologists that are always on fire and they're just quick and efficient. And some that, when you see them, you're like, oh, they're just much more methodical. So I think that we have the opportunity to even use that for anesthesia to say, hey, these are ways that your highest performing actors are doing it versus the people that are slower, to try to help them improve their efficiency, because turnover time is one of those things for a surgeon that you feel like is less in your control. I think sterile technique is ways that we've been using it in position where we've been using it for positioning and sterile technique and ultimately turning the room over. I think those have all helped a lot, but I still think there's opportunities for improvement, specifically in how we make sure turnover is happening. And, I think we can do the same thing in the endoscopy suites. How are we getting the case going? Why are some people moving faster than others? Is it because they're not safe, or is it because they're more efficient? If they are more efficient, how can we, get that to trickle down to their partners? And so I think that I don't think we're barely scratching the surface in how we can use that.
Great. Well, again, Pete, it's a pleasure not only talking with you for this 45, 50 minutes, but a pleasure working with you. And I'm really confident that the work we do together over the next year or two is going to be pretty transformative. And I'm looking forward to that.
Yeah, I can't wait to do that.
Thank you.
Yeah, thanks, guys.
Thanks for joining us for another episode of Data Nerds in the OR, a surgeon's journey toward value-based care. You'll find links in the show notes to any resources mentioned in today's show. If you're enjoying our podcast, please subscribe so you never miss an episode. And if you want more content like this, you can always sign up for our Smart Surgery blog via the link in the show notes. Or if you want to ask Dr. Remshaw or the team a question directly, please send an email to podcast@caresyntax.com. This episode is brought to you by CareSyntax, the leading vendor-neutral surgical intelligence platform. The CareSyntax platform can ingest and analyze data throughout the surgical workflow, including clinical, operational, financial, and outcomes data to capture a complete picture of the surgical pathway. That data can produce actionable insights to enhance efficiency and innovation for surgical teams, hospital administrators, and medtech developers, driving innovation for the future of healthcare delivery. CareSyntax impacts over 3,000 ORs and more than 3 million annual procedures across the globe. Learn more at www.caresyntax.com.